Hi guys, I hope you are doing well today. And today we are going to talk about pelvic floor dysfunction. We're going to talk about pelvic floor therapy and some of the innovative treatments there are to improve the tone of your pelvic floor. And really, it's not just improve the tone, but improve the overall function of the pelvic tone. And then, as you guys know, I like to look at a few research studies and kind of walk through those with you so we can all discover together how we can apply this information to help our symptoms. Okay, so first of all, let's talk about the pelvic floor and why it is important. So the pelvic floor is made up of multiple muscles that kind of come in layers, and essentially they form this bowl. And maybe I'll put a picture of this. And in that bowl, it kind of hooks into your tailbone area and goes all the way up to your pubic bone, or that front part. The front bone you can push up here. And for a woman, you have several things kind of resting on that. Your colon comes down in the back part, and you have your rectum. And then you have your uterus and vagina, and then you have your bladder that's kind of pushing in the front. And each one of those has an opening. And for men, it's similar without the uterus. And so those pelvic floor muscles, there's a lot of pressure inside the abdomen pushing down on those pelvic floor structures. And so if those muscles have problems, it can create all sorts of other issues. And so one of the issues could be like an organ prolapse. And that is if, let's say, the bladder comes down through the urethra into the pelvic floor, or not through the urethra, but through those pelvic floor muscles. If the uterus comes down, or the rectum, any of those can actually prolapse or come through the muscles. And the best way to think of that is that's almost like a hernia in that area. And so there's really kind of 5 different important roles of these pelvic floor muscles. The first one is organ support. So it kind of holds everything up. And just like we talked about, if it's too weak, you can get a prolapse where part of those organs are coming down. The other thing it does is it's really attached. From there, it goes up to your core. And so you have your back muscles in the back and then your abdominal muscles in the front. So that holds everything in this abdominal container that each of us have. And so we're realizing more and more how important a good, strong core is for almost all of our functioning. In addition, it's responsible for some of the effects of sexual functioning. And so for normal sexual functioning, you have to have an intact pelvic floor. One of the interesting ones is circulation. And so you wouldn't think, obviously, it's not a heart. There are certainly blood vessels going to those muscles, but what it ends up doing is, as we're walking and moving, it's almost a pump that brings stuff back up to the heart. And so that's one of the reasons why movement is so important, and the pelvis actually plays a role in circulation in that regard. And then the one that we're going to talk mostly about is really sphincter function, and how that affects us for things like bladder problems or even bowel problems and what those look like. So I will post a picture of these muscles, and they, like I mentioned, they really form this kind of tight band. So there's bones in the front and the back, and then muscles all in between those. So strong pelvic floor muscles give you control to some degree over your bladder and bowel, or I should say allow you to have control over your bladder and bowel. So if you have really weak pelvic floor muscles, it's going to be more difficult for you to control those things. And let us look at, so here's some of the risk factors for having pelvic floor dysfunction. So one of them is prostate surgery for men. Anytime we go in surgically and change things around, it affects those muscles and those surrounding structures, and sometimes will affect those nerves. Another one is age. Just as we age, all of our muscles are losing their strength and power, and these pelvic floor muscles, if we're not doing anything to maintain them, tend to weaken over time. For women, pregnancy and childbirth tend to cause some premature aging in those structures. And I always mention this hormone that we make, or women make when they're pregnant, called relaxin, that relaxes all the structures in our body, getting ready for the baby to come out. And so that hormone relaxin really relaxes ligaments, tendons, and even muscles. And so sometimes those things don't come back together. Oftentimes the kind of incontinence that happens after pregnant women give birth is called stress incontinence. If you laugh, cough, or sneeze, that's a muscular problem where those muscles aren't able to hold, the sphincter isn't able to hold the pressure of the urine back. The fourth factor that's a risk factor for pelvic floor dysfunction is genetics. So, if your father, mother, sister, siblings have this problem, there could be a genetic component. Kinds of intra-abdominal surgeries, and so a big one being like a hysterectomy, increase your risk of having problems here. I also hear about things like bladder lifts, where they go in and try and lift up the organs. That can affect the internal anatomy. Number 6 would be a direct pelvic floor injury. So if you've had some kind of trauma, I treated a lady who had a slip and fall and basically was forced into the splits. And that immediately started this pelvic floor dysfunction. She tried therapy, tried all sorts of things, nothing really worked, but she actually found relief of incontinence with the therapy that I specialize in. Today I'm not going to really focus too much on that. I'm going to talk about the other kind of more I would say traditional routes of therapy and what those look like, and also some kind of newer technological innovations. Increase intra-abdominal pressure also is a risk factor, and that goes hand in hand with the number 8, constipation. So anything that's increasing the pressure in there really causes and affects that pelvic floor. Intense physical effort, and so oftentimes we'll hear about stress incontinence, laugh, cough, or sneeze for a woman if she's running, jumping on a trampoline. So there's really an intense physical effort, increased intra-abdominal pressure, and then those pelvic floor muscles have been relaxed over time and really have a difficult time holding the urine back. Obesity, because it just creates more pressure inside there, and then a history of back pain. So all of those are risk factors. And as you can imagine, probably most of us have one or two of those risk factors. Okay, so let us look, and so first I'll mention you can have too much muscle or pelvic floor tension, and so that's called hypertonic, and so that would be like spasms. And then the other one is kind of what we mostly have been talking about, I would say, is more hypotonic. The muscles aren't strong enough, the contraction isn't strong enough. And so there are, so that's something that can be determined, but if you feel like, a big part of what you're suffering with is, pain and some of those things, it could be hypertonic, and of course it can be a little bit of both of those things. I'm going to mention and if you guys have any questions, jump right in. I'd love to hear those questions. And I'd also love to hear your own personal experience with pelvic floor therapy. Did it help you? Did it help bladder issues? Did it help other issues that you have? And so one of the things I'm going to talk about right now is the symptoms and prevalence with pelvic floor dysfunction. So if you have this, what are your most likely symptoms? Because that would be important to figure out. The number one is pelvic pain. And so if, let's say, you have incontinence but you don't have a lot of pain, that would be lower down on the list of potentially if you have pelvic floor dysfunction. Now, there is a thought that most people with incontinence have some degree of pelvic floor dysfunction, and that is probably why almost everybody can benefit from some degree of therapy, whether it's simple Kegels exercises at home, whether it's physical therapy with a specialist in this arena, or whether it's some of the other modalities that I'm going to mention here. The next most common problem is urinary dysfunction. And so that affects close to 80% of people. And so that can be anything from, I have a strong urge to go. I have stress incontinence. I'm leaking a little bit when I laugh, cough, or sneeze. I have urgency. I have incontinence. Any of those things fall under that urinary dysfunction. So it's a really wide bucket of symptoms. The next most common is orthopedic pelvic pain, and so that goes right along with pelvic pain. But what that means is you might have pain in your hips, pain in your back, and so you're not recognizing it necessarily just as like pain around, let's say, your rectum area or perineal area, but instead you're saying, oh, I have pain in these other areas, but they're coming from your pelvis itself and manifesting in these other areas. The next most common is prolonged sitting increases your symptoms. So if you're wondering, do I have this? If you sit for long periods of time and then you start to develop some pelvic pain, that might be one of the early indicators. The next most common is bowel dysfunction. And then we run into tailbone fall. And so remember I mentioned the lady who slipped and fell. She didn't have a fracture of her tailbone, but she certainly had some damage to her pelvis. She actually ripped a few of the muscles and tendons. And so she had a significant fall or trauma that led to some of these other symptoms. And she actually had bladder and bowel dysfunction, both of those. The next most common is pain with intercourse. And then finally, we're looking at nocturia or nighttime urination frequency, and then a prolapse itself or feeling of prolapse, like I feel like my organ's coming down. So those are kind of the symptoms prevalent. So I will put a list of that in the show notes here today. And then I'm going to break it down by a few other things just so you kind of really understand. And so if we're talking about pelvic floor dysfunction, if you have problems while you pee, sometimes it manifests as pain, urgency, frequency, difficulty voiding, urinary incontinence, and then we really talked a lot about stress incontinence, laugh, cough, or sneeze, and you're leaking. Problems with pooping also could manifest as pain, urgency, frequency, difficult avoiding, and then incontinence. Sex, pain, we mentioned that. And then organs, you might have pelvic organ prolapse, pain, and then I will also include in there constipation and those kinds of things that are inside but affecting that. In just a minute, I'm going to get to some of the studies, but I think some of the really common symptoms that people might feel: stress, urinary incontinence, or frequent UTIs could be one of the manifestations of pelvic floor dysfunction. A heavy dragging sensation in your abdomen or kind of in that low area in your perineal area, which is, all the way from your pelvic all the way back to your tailbone. Bowel incontinence or obstructed defecation, excuse me, and itching. Okay, so let's look at what some of the research says in relation to pelvic floor dysfunction, and what are ways that we can actually address some of those issues with therapy and with muscular control. Now, I think I've said in the past that overactive bladder, is a unique condition that's we think is actually caused by nerve problems, so the nerves aren't functioning properly. Indirectly, that does affect the muscles, though, and vice versa. If you have a muscular problem, indirectly that affects the nerves. And so it's one of the reasons why I think pelvic floor therapy is something that everyone should probably incorporate, especially if you're having any symptoms of incontinence. So there's not a whole lot of wonderful studies, just to be honest, on pelvic floor therapy and what the really big benefit is for overactive bladder. And that would include even things like Kegel exercises. They're just not great research on that. I did look at one research study that I thought was worth mentioning, and it was published in 2017 in the Neurourological and Neurodynamic Research journal. And so this one looks at, and this one's kind of interesting because it looks at the outcomes of different protocols for pelvic floor therapy and anticholinergics or medications for bladder problems in women who have wet, overactive bladder. And so, really, wet, overactive bladder is you have urgency, frequency, nighttime urination, and incontinence. And so, really, it picks up that last part, incontinence, because some people don't have incontinence, but they have these other cluster of symptoms. One of the unique things about this study is it goes out over 4 years. So we've kind of reviewed a few different studies. So I like that. That means it's a long-term study. There are some pros and cons to this study, but essentially what they did is they had 164 people originally. They put them into 4 different groups. So people who just got a medication or a drug, people who got bladder therapy. So someone talked to them about their bladder and about how they should formulate their day and how much time they should take in between trying to go to the bathroom. The pelvic floor muscle training group, so that's the third group, and then the fourth group is a combination group of pelvic floor training, bladder therapy, and behavioral advice. So this group actually got a little more attention and a little more focus. So this study looks out over 4 years. It's only a survey study, so that's not like a real strong kind of study. And then unfortunately with 164 people, when you divide them into 4, it really ends up being a small number of people in each group. And at the end of their study, they were left with 132 patients instead of 164 because some people moved, some people didn't want to take part in the study. You know, you can figure out some of the other reasons. But 132 people were left at 4 years. And so really, you know, we're looking at somewhere around 35 people or 33 people that are left in each group. Okay? So now I'm going to tell you the results because, you know, telling you the study design, if it's a well-designed study or not, and what they did. So in the drug therapy group, one of the things they tracked, so they really tracked 2 things. One of the things they tracked is urinary urgency incontinence episodes. So those episodes where it's like, oh, I gotta go. Oh, I didn't quite make it. And so what they found in the drug therapy group, now these kind of drugs are not wonderful drugs for the problem of incontinence. And mainly we know that they, you know, really increase your risk of of dementia. And so that's the single greatest risk, I would say, for these medications. They also increase your risk of falling and getting fractures, which is extremely dangerous and deadly for people as we age. But in the drug therapy alone group, those incontinence episodes decrease for a week total by 3. So let's say you had, you know, 10 incontinence episodes per day. You know, that'd be really bad. You would see a reduction on 3 of those days. It would go down to 9 episodes a day, if that makes sense. So that for you would not be significant. Now let's say on the other hand, you were somebody and you only had 3 incontinent episodes in the week altogether, and then this dropped by 3, that would be significant. So it's really difficult actually to determine because we don't know all the information, how many on average incontinent episodes these people had. But it dropped for the week by 3. And then what we do know is they looked at dry. What percentage of people stopped having incontinent episodes altogether? And in the drug therapy group, it's about 25%. So 1 in 4 people look like they stopped having incontinent episodes altogether. That's not wonderful, but it's also not terrible. Having said that, I don't think the risk outweighed the benefits for most people because it really increased the risk of dementia, falling, and some other medical problems. Okay, so that's the first group. Now we're going to look at the bladder therapy group. So this one just had bladder therapy. They didn't have a drug. They dropped by 1 of those incontinent episodes per week. Remember we said the drug dropped by 3. But the interesting thing is 31% of the people in that group said they were dry versus 25% in the drug. So, you know, you can see how sometimes when we get information, it's really confounded. Another thing we don't know is what's the average number of incontinent episodes each group had. That would be important for us to know. And then what percent of those. So we'd like to know that information. And then if any of them were dry beforehand or not. So that would be important for us to know, but we don't know that. So bladder therapy looks like it has some effect, maybe not a dramatic effect, but for whatever reason has a slightly percentage of higher dry people compared to the drug. Now let's look at pelvic floor muscle training. So this would be if you and I decided to do Kegel exercises 3 times a day. And so this is what most people get, a pelvic floor therapist might recommend. So this is the most common, I would say, therapy that people are getting. And so this group, it dropped by 2 the number of incontinent episodes per week. So far the drug is actually better than just straight up pelvic floor exercises. Because the drug dropped by 3, this dropped by 2 episodes per week. And then we had 44% of these people said that they were dry. So again, this is, so that looks more successful than the bladder therapy and more successful than the drug therapy. But for true incontinence, it was a lower number than those other 2. So, those results, and part of this, like I mentioned, is there's just not many people. It doesn't end up with many people in each group. So if you have 1 or 2 people who really become dry, that makes a huge difference in the numbers. And so if this study, instead of having 132 people completed it, if it had 13,000 people that completed it, these numbers would actually be more meaningful and probably closer to reality than they are. Having said that, there's not a lot of studies, and so that's why I picked this one. Okay, the last group is a combination pelvic floor, rehabilitation, bladder therapy, and behavioral advice. So these people really, they threw the kitchen sink at them. They're not on medications, but they're trying all these other conservative things together. So just in my mind, and in your mind, you might be thinking, okay, this group probably did the very best because they're getting the most direct attention. They're learning all the tricks of group 2 and group 3, putting it all together and getting some additional coaching. What's interesting is their urinary incontinence episode dropped by 2. So that really matches just pelvic floor alone. It doesn't match the drugs, which was 3 per week. And then 34% of them became dry. 1/3 of them essentially 1 and 3, which is interesting because it's less than if they had just done the pelvic floor muscle training, which was 44%. So what that tells us is generally this study should have had way, way, way more people, and we would have better numbers because technically, if you're doing both groups, those 3rd and 4th group both did pelvic floor therapy, but it seemed like the ones who only did that, really benefited more than the ones who added in some additional things. Okay, so from that, it's very hard to make a recommendation that pelvic floor therapy is dramatically going to improve your urinary incontinence episodes. And again, this doesn't break it down between incontinence episodes or stress necessarily. And so that's one distinction that would have been nice as well in this research study. Generally, when I think about physical therapy, I think of stress as being a muscular problem, and physical therapy would be wonderful for that. Urinary urge incontinence is more of a nerve problem. Physical therapy, I think, should be good for that. And then there's something called mixed where you have a little bit of both. Again, physical therapy should be good for that. So what we saw in this study is physical therapy did benefit people. And drug therapy also had some benefit as well. They didn't do a group that was on medications and doing physical therapy. Okay, so like I said, there's not a lot of great studies on pelvic floor therapy for overactive bladder. This is one of them, actually, that's just for overactive bladder. And I thought it was a nicely designed study. Maybe, didn't quite have as many people as would have benefited, but at least it went out over 4 years. Okay, I'm going to talk about 2 other technologies today that I think are worth looking at. The first one is called the IMSLA chair. And I think, I've had a lot of patients who have tried this. I've had a lot of people ask me about this. In the literature, it's high intensity focused electromagnetic field therapy. and then we call it insulatherapy. So any research articles that have written about this are high intensity focused electromagnetic fields, or HIFM. And so there is a study that looked at women. And this study looked at 75 women. So again, not a very big study. It only followed them for 6 weeks, I believe. And it looked at women who had stress incontinence, urge incontinence, and mixed a little bit of both of stress and urge. Now, if I was just thinking, if I was betting, I would probably bet that this therapy, and so ImSolaChair, what it does is it sends these high intensity electromagnetic, you sit on a chair, high intensity electromagnetic signals, and basically causes a lot of these contractions of your pelvic floor. So what they've said, I think, is like in one session, which takes 20 to 30 minutes, your pelvic floor will have contracted 10,000 times, and it'd be like doing Kegel exercises, all during that time, 10,000 Kegel exercises or something like that. So what they're saying is we're really able to target the pelvic floor muscles better than just pelvic floor therapy. That's why I'm bringing this up, is it's like maybe an extension of pelvic floor. There's been a bunch of different studies. Not many of them have looked at the condition overactive bladder. They have used this for pelvic pain, for hypertonic, like muscle spasms, and it does seem to benefit those people. What this study showed is 81% of women at 6 weeks, remember, not a long study, 81% of people reported 50% relief. We, again, don't know what percentage of women had stress, what percentage of women had overactive bladder only, and what percent had mixed. And that's a really important distinction, because we would think that this would probably work better for maybe the stress kind of incontinence or just the muscular kind. One of the drawbacks of this is it's cash pay, and for most people it ends up being thousands of dollars. So I've seen a lot of patients who've done this, and they said, I think I saw one lady, and she's like, I've spent, $4,000 on this, and I've done it a few times, and it worked initially, but now it's just not working anymore. And so one of the problems is, I think, this is something that has to keep going on. We don't know if this lasts, so we said, maybe 81% of people got 50% relief. We don't know what happens at 10 weeks and 12 weeks and 6 months and 1 year. And we just know exactly while they're doing this therapy. Having said that, if you have the time and you have the money and you want to try it, I've tried it. I've sat on the chair, and it's an interesting sensation. If you want to try it, I'd say go for it. I don't think we lose anything by that, except maybe our time and money. There haven't been really wonderful randomized controlled studies looking at this. So it's probably not the first course of therapy that I would recommend. If you have the type of insurance where you bank up your own money and can spend money however you want to, you probably can actually spend your money on something like this if you wanted to. I just don't know if this is what I would spend my money on. There's another interesting device, and there's some different versions of this. I talked to a gentleman earlier today, and he said he's been trying a lot of Kegels exercises, and he's been trying some version of TENS unit, which is almost like a little device that you place inside your rectum and really stimulates all the nerves there. And there are different versions. Women have a version that they place inside the vagina that's supposed to stimulate those muscles. So there are different versions of that. Again, I don't think those things have wonderful studies, although they may be beneficial for some people. So there's this other device called Elitone, and it almost looks like a pad that a woman would wear, but it has electrical contacts on it. And so what this is essentially is like a TENS unit device for the perineal area, for the area down there. This study was 32 people. It's not randomized. So these 32 people all got the therapy. So again, our critique, not a very big study. We're not looking at how these people have done on if they would have done placebo or nothing. We don't know how it compares. It's a 6-week study, so again, not a very big study. But they did this stimulation. They placed this little pad. It has gel. It's hooked up to a little electrical contacts. You have a little like TENS device. You turn it on. It's a 20-minute therapy, and they would do that every single day for 6 weeks. So the idea is they're stimulating those pelvic floor muscles, similar to the chair, similar to Kegel exercises. They're trying to wake up those pelvic floor muscles. In their study, 85% of people had a 50% reduction in symptoms. So very, very similar to the MSILA chair. Again, it's a $400 device. If you want to spend the money, I would say go for it. I don't know if it's any better than just doing Kegels yourself. It hasn't been studied. It hasn't been compared to just doing those exercises yourself at home. Let's see. That device I think I mentioned was called Ellatone. And so I think it's a good idea. I would be more interested in what, again, like I said with MSILA chair, what happens at 10 weeks, 12 weeks, 6 months, 1 year. Is this a therapy that works for a really short period of time, or can you continue to use it all the time and continue to get relief? Hasn't been studied, and so we just don't know. This device does work. They market actually 2 different devices. This device does work to some degree for stress incontinence, which again I would expect if we can strengthen those pelvic floor muscles. The stress incontinence, laugh, cough, sneeze type of incontinence should really help out, because those are all the supportive muscles that hold the bladder up, and so I would expect that would give some relief of those. I am just going to remind everyone, what I specialize in is called sacral neuromodulation. And so it is a different technology than these. It does use electrical stimulation, but it stimulates the nerves. And the idea is it opens back up the communication between the bladder and the brain. Long term, it looks like the most successful thing. There's 2 steps. You try it out first, see if it works for you. If it does, then we implant the little device. The long-term success rate is 93%. 93% of people feel like it's a great therapy for them, and that it gives them over 50% relief of their symptoms. And that's long-term, so that's looking at years worth of the therapy. The average person gets a 75% to 100% reduction in their symptoms. So many of the people that I use that therapy on have tried all these other things and just not received significant relief. The gentleman that I talked to earlier, he said that Kegel exercises and that little stimulation that was kind of rectally based actually really helped his urgency, the real strong desire, and even the frequency during the day, but it didn't do anything for his symptoms at nighttime. And so he actually wanted to try the therapy that I do because he's waking up 5 times a night and his quality of life is really, really low. So I think the take-home message is here. Your pelvic floor is very important. It has several different functions beyond just controlling your bladder and your bowels. There are people who have too much tone or spasticity, and oftentimes that'll manifest as pain with sex and pain and spasms and those kinds of things. And then there's the hypotonic, where it just doesn't have enough tone itself. I would say most older people are more likely to have the hypotonic, where it's not strong enough. Generally, I feel like almost all people can benefit from some degree of pelvic floor therapy, just like all of us could benefit from working out. One of the really interesting things, and there's no study on this, but it's just something I'll throw out there because I think it's interesting, is there are some different research studies where they have people work out one big body area. So let's say it's your legs. That's all you do. You don't work out any other area, just your legs. That basically stimulates hormones in our body to build up all muscles. And so those people actually had a benefit in their arm strength, even though they were only working out their legs. And so we see the same thing in, for instance, like sprinters. They might never lift weights, but sprinting is a very anabolic exercise and creates growth in muscles. So I'd almost be interested to see what if I just worked out, and I didn't do any pelvic floor exercise, I just worked out, would that strengthen the pelvic floor? And my suspicion is the answer would probably be yes. And one of the biggest risk factors for all of us as we age is decreased muscle tone. And so decreased bone density is called osteoporosis, but we can have sarcopenia, which is the muscles have become poor or weak. And that's very, very common as we age. And there's a lot of research showing the stronger our muscles, the better our quality of life will be long term. So that would be a fun study, I think, to study or to look at for people. Hey, if I just walk around the block and work out my legs, would that strengthen the pelvic floor? But certainly, I think there's a place for pelvic floor therapy. I am going to have a pelvic floor therapist who specializes in this come in, and I'm going to interview her. I've already arranged that, and so I think that'll be fun. I think she deals a lot with, and I'll ask her, but I think she deals a lot with people with pain, with muscle spasms, and those maybe pain with intercourse, all of those sorts of things. It may be a little less common with overactive bladder symptoms, but let's ask her. All right, guys, let me see if there's any things that I haven't touched on. Well, I certainly would recommend that you do some pelvic floor therapy and do some of those Kegel exercises. And if you want to try some of the other things, I'm a believer. You might as well try them. I don't think any of us have much to lose. And I would say, God bless you guys. Have a wonderful day. And I would love to hear your comments and thoughts. Has pelvic floor therapy worked for you? Have you seen any benefits from it? What symptoms has it helped? What symptoms has it not helped? Okay. Well, that ends it for today. You guys have a wonderful week, and I will be joining you next week for a new discussion. Thanks so much.